Hello, everyone. Thank you for joining the Genetic Aortic Network, a division of the Marfan Foundation, for our webinar titled Best Practices for Preclinical Thoracic Aortopathy Studies. I'm Lauren May, Senior VP of Research at the Marfan Foundation. Today's webinar will feature a discussion on highlights from the review, recommendations for design, execution, and reporting of studies on experimental thoracic aortopathy in preclinical models, published in ATVB in March 2025. For this webinar, we will use Zoom's Q&A functionality to field any questions you may have about today's presentations. Please select the Q&A tab on your screen to submit your questions anytime during the webinar, and we'll cover as many as possible at the end of the session. Also, this webinar is being recorded and will be posted to the Genetic Aortic Network's website in the next few days. I am honored to introduce our speakers for today. Alan Daugherty is the director of the Saha Cardiovascular Research Center at the University of Kentucky. His research interests are in vascular pathology with a focus on atherosclerosis and aortopathy. As a bit of background for this webinar, Dr. Daugherty's time as editor of Arteriosclerosis, Thrombosis, and Vascular Biology, or ATVB, the NIH introduced guidelines on rigor and reproducibility, which became an issue of engagement for the journal. This involved developing technical editors to assist with compliance with NIH guidance. It also included developing statements that provided recommendations to standardize research platforms. The webinar today will discuss the recent ATVB recommendation that aims to provide guidance to the community on experiments related to aortic diseases. Scott LeMaire is a professor of cardiothoracic surgery and serves as the Associate Chief Scientific Officer, Associate Dean for Research, and Chair of the Department of Investigational Medicine at the Geisinger College of Health Sciences. His research interests include organ protection during aortic surgery, genetic aspects of thoracic aortic disease, and molecular mechanisms of aortic wall degeneration leading to aneurysms and dissection. Dr. LeMaire is a past president of the Association for Academic Surgery, and he currently serves as president of the Southern Thoracic Surgical Association and editor-in-chief of the Journal of Surgical Research. Hisashi Sawada is a physician scientist specializing in vascular biology, with a particular focus on the extracellular matrix of the aortic wall. After completing his clinical training in cardiology, he pursued postdoctoral research at the University of Kentucky, where he studied the role of smooth muscle cell origins in thoracic aortic disease with Dr. Daugherty and Dr. LeMaire. His work has identified distinct embryonic origins of aortic smooth muscle cells and revealed the unique contribution of second heart field-derived cells to aortopathy. These studies were conducted through multi-institutional collaborations and have contributed to publications in journals such as Circulation and ATVB. In 2025, Dr. Sawada moved to Japan as part of the JST Expert J program and is currently leading a laboratory at the University of Tsukuba. His research now focuses on vascular repair and regeneration, particularly the role of progenitor cells and de novo elastic fiber formation in diseased aortic tissue. By integrating advanced imaging, lineage tracing, and multidisciplinary approaches, his goal is to bridge basic vascular biology with translational applications and ultimately develop novel therapies for aortic aneurysms and dissections. Dr. Daugherty, the floor is yours.
Hopefully our slides are now present on the screen.
Yes.
All right. Good. Thanks, Scott. All right. Well, good morning, afternoon, or evening, depending on where you are in the world. It's our pleasure to present this webinar, which is going to be constructed between the three of us in this mode. So the origin of this webinar was based on an effort that many of us made some time ago to try and create a manuscript that gave recommendations for the way in which you perform experiments experimentally to try and get really informative data from animal experiments that could be translated to humans. This is a very substantial document. We don't intend to go through every facet of this today, but hopefully we'll be able to give you some of the sort of more important issues, and then we're very happy to expand on it during question time. So it basically covers the fact that we think about both the animal model, from how it's induced, the characteristics of that model, the mode of which the disease occurs, and then measurement and characterization. The reason that we really got into this is this really large increase in the interest in this particular area. So this is metrics from PubMed when you've just got these search terms of aorta aneurysms and aortic dissection. You can see over a 20-year interval, there's been a vast increase in the number of interest in experimental, sort of publications in this topic. And so we thought it was a timely manner to both help facilitate people getting into this area and maybe to try and provide some basis for standardization so that different labs could do comparable studies. So the highlights that are represented in this particular article are that thoracic aortopathy can be generated in many mouse models using different chemical and genetic manipulations, either alone in combination. There are many elements of the experimental design that really need to be considered, which we'll go through, such as sex, genetic background, and age. The studies really should be executed with pragmatic considerations of methodological strengths and limitations, and ensuring that the acquired data are appropriately analyzed using robust statistical techniques. And then the last highlight that was in the article was reporting of studies should provide raw data and complete descriptions of experimental conditions to really help facilitate the reproducibility. So the first part of the seminar will be given by Scott, who'll talk about features of human aortopathy that are replicated in mice. So Scott.
Scott, you're on mute.
Here we go. Thank you, Alan. When it comes to trying to understand the pathobiology of thoracic aortic disease, the vast majority of preclinical research involves mouse models. The goal over the next few minutes is not to catalog every model, but to highlight the ones that have been most informative. I'll also discuss which human disease features are faithfully modeled and where important gaps remain with implications for translation. Next slide, please. So grossly, the aortas of humans and mice have similar branch vessel configurations. And both humans and mice have aortas with 3 layers, the intima, media, and adventitia, and these layers comprise the same cell types. Further, many genes that cause heritable thoracic aortic disease, or HTAD, in patients also produce disease in mice. Next slide, please. Despite those similarities, there are also important structural differences. For example, the aortic wall in humans has about 60 to 70 elastic lamella within the media, whereas mice only have 6 to 8. Also, humans have a medial vasa vasorum, and mice largely do not. In addition, although blood pressures are similar, other key hemodynamic parameters, including heart rate and aortic shear stress, differ substantially. These differences likely explain why dissection morphology and progression differ between species, as I'll describe later. Thus, while mouse models are useful in understanding mechanisms of disease, they do not do so with full clinical fidelity. Next slide, please. Several models have been described in which chemicals were administered to induce aortopathy in wild-type mice, but I'll focus my comments on 2 that are most commonly used. The most widely used chemically induced model involves infusion of angiotensin II using a subcutaneous osmotic pump, a model pioneered for studying aortopathy by Dr. Daugherty's group in the late 1990s. Angiotensin II infusion produces aortic aneurysms, aortic dissection, and rupture in each of the thoracic segments as well as the suprarenal abdominal segment. Importantly, the aortic phenotype in this model occurs independently of Ang2's influence on blood pressure. Next slide. The next most commonly used model involves oral administration of beta-aminopropionitrile, or BAPN, which inhibits lysyl oxidase, thereby impairing collagen and elastin cross-linking. Provided that BAPN is administered within the first 4 weeks of life, this model closely reflects the extracellular matrix degradation seen in human genetic disease and the key clinical endpoints of aneurysm, dissection, and rupture. Both the ANG2 model and the BAPN model are easy to employ from a technical standpoint, and they are excellent choices for studying mechanisms of wall failure. Importantly, in both models, disease onset is rapid and often more severe than typical human disease, particularly that seen in patients without heritable aortopathy, which tends to be a slowly progressing development of aortic wall degeneration. Next slide, please. There is a large and continually growing number of aortopathy models that employ genetically manipulated mice. The targeted genes code for proteins involved in three key areas. Those related to the extracellular matrix, those related to smooth muscle cell function, and those related to the TGF-beta signaling pathway. When selecting a genetic model, it's important to recognize that none of them captures all aspects of human disease, and that phenotypes depend on gene, age, and context. The most commonly used models focus on Marfan syndrome and involve mutations in the gene encoding fibrillin-1. The Marfan models produce manifestations concentrated in the aortic root and ascending aorta, and they reflect the genotype-phenotype relationships we see in patients quite well. The missense C1041G model, shown below on the left, is characterized by slow aneurysm growth with low dissection and rupture rates despite high levels of dilatation. In contrast, the hypomorphic MGR model, shown on the right, produces aggressive aneurysm development and early rupture. Next slide, please. In contrast to the FBN1 models, many smooth muscle cell contractile gene variants cause vulnerability to wall damage rather than disease endpoints. However, some smooth muscle cell specific deletions of key regulators, such as LRP1 and YAPTAZ, produce robust disease. There are several models focused on the TGF-beta pathway, including with mutations involving ligands, receptors, and downstream signaling effectors such as SMADs. Work with these models has revealed strong dependence on developmental timing and cell specificity. Although the role of TGF-beta in human thoracic aortic disease is controversial, mouse models having loss of function manipulations in mice generally promote thoracic aortic disease. Next slide, please. To increase the penetrance and severity of disease, some investigators have used models that combine genetic susceptibility with chemical stressors, particularly ANG2 and, as shown below, BAPN. These models introduce quote-unquote second hits that are often encountered in HTAD patients, such as hypertension or exposures to factors that exacerbate extracellular matrix injury. Although the resulting disease may exceed what is typically observed clinically, these models can be useful for exploring interactions between genetic conditions and exacerbating comorbidities. Also, they're useful for accelerating disease in therapeutic experiments. Next slide, please. In many of the mouse models, disease progression results in accumulation of blood within the aortic wall. Importantly, at least in the ANG2 model, the source of blood is clearly an intimal medial tear, as shown here, paralleling what we observe in patients with aortic dissection. However, the location of the blood may differ. In contrast to humans, the blood is often seen more in the adventitial medial boundary or the outer aspect of the media. Further, in mice, we do not see evidence of persistent patent false lumen with flow and distal reentry sites. Consequently, mouse models are not well suited for studying chronic aortic dissection. Finally, while both dissection and rupture are, of course, valuable endpoints, tissue studies after these events offer limited mechanistic insight. Post-dissection and rupture specimens reflect the results of wall failure and the response to the acute tissue injury, not the state of the wall preceding the event. Next slide, please. So to wrap up this portion of the session, mouse models are clearly indispensable for understanding aortic pathobiology. Different models reflect different mechanisms, and their diversity mirrors the heterogeneity of human disease. Selecting the right model requires clarity about the pathology of interest and the mechanism being tested or targeted. Because no single model captures all features of aortic disease, when testing new therapeutic approaches, one should consider conducting a series of experiments using different complementary models. In conclusion, when used thoughtfully, these models remain our most powerful preclinical tool, provided we recognize their limitations and carefully design experiments to mitigate them, which Alan will cover next.
All right, thank you, Scott. So as mentioned, I'm going to go through the experimental issues that were listed in the manuscript. There's many of these. I'm not going to go to any of them in any great depth. So the general issues are just that we've really tried to push when we considered this about being very consistent with guidelines that include the fact that you should really make sure prospective protocols are put together with primary and secondary endpoints, that there is prospective inclusion-exclusion criteria, so that should rule out determining, should be include rules determining in advance for terminating experiments. Modes of randomization of mice to specific groups, and the approach to blinding. This is all becoming very standard now in terms of many journals requiring responses to this type of design prior to acceptance of manuscripts. First thing we're just going to mention here is sex. There is actually not a great depth of literature on the role of sex in experimental thoracic aneurysms. Having said that, there is some very great consistencies. This is just two examples of the very commonly used 1041 mouse, in which one group you can see has done both the ascending and the root, and then another group, Hisashi Sawada group, that's done very similar data and has got very similar responses. If I could just accentuate over here, where you can see that males and females, although they both are extended over the wild type animals, beginning, if you look over a year time with sequential ultrasound, you can see that the females actually progress at exactly the same rate as wild type, where the males have a pronounced increase. And this has been consistent in many experiments. So there is a considerable need to make sure that sex is very specifically stated. This is also another example, not just size, but actually the structure. In this case, this is the model created by Kiko Ramirez, the MGR model of fibrillin 1 hypomorph, in which, as you can see, the males in extended age have profound elastin fragmentation, but the females at this same age actually have a rather attenuated presence of elastin fragmentation. So we did very specifically state that sex really should be stated, and preferably experiments should be done separated by sex unless no difference can be defined. The other aspect that we've noticed has had a huge influence actually is genetic background. So for example, in the BAPN model, this was published last year, in 24, in which 5 different strains were characterized for the susceptibility to BAPN-induced aortopathy. So the commonly used C57 strain, which is usually the J, you can see is very susceptible and very similar to the N. But strains, species such as 129, which is very commonly used for making genetically manipulated animals, you can see have a very different susceptibility. So it is very important to be thoughtful about the strain that you use. And I just wanted to make an issue that we didn't accentuate quite so much in the recommendations, is that there really needs to be quite a lot of detail about this. So for example, the C57 strain, a lot of people will state that it was C57 background, but in fact there is very well defined differences even within the C57. The biggest separation of these is the N and J. And part of the reason I'm accentuating this is that many of the mice that are made with genetic manipulations are made with stem cells that are from the N strain, even though they're subsequently bred into the J strain. So I think we were all very in agreement that there should be an encouragement to be as specific as possible about the strain, the genetic background of the mice that are being used. Blood pressure has been somewhat of a slightly controversial issue because many of the factors that do promote thoracic aortopathy do also have an effect on blood pressure. This is one example in which that was separated, in which case these are smooth muscle LRP1 deficient mice, in which there was a comparison to the infusion of angiotensin and norepinephrine at equivalent pressor doses. And the data you can see both by visualization of the tissue as well as oops, I'm sorry, there's a graph meeting there. The bottom line is that the angiotensin caused a very profound expansion in this particular model, which was not mimicked by equi increase in blood pressure during norepinephrine. However, it's still not quite clear. Some of the members of the writing group published this publication last year in which they looked at the combined TGF-beta 1 and 2 deletion using the MAH11 lineage cells, and then did a relatively short-term infusion of both norepinephrine and angiotensin, causing actually a slight difference in the blood pressure and getting equivalent dissections in these animals. And they also did a very acute experiment where after deleting these two TGF-beta receptors, then they did a bolus infusion and also measured blood pressure and found that there was an equivalent state of dissection. So I think we were a little soft in this recommendation, saying that while there is evidence that blood pressure may be not the per se driving factor, it is recommended that people measure blood pressure in the experimental procedures they're reporting on. In terms of age, I think it's becoming fairly clear that while there's not a lot of data, the few examples around that have done equivalent manipulations of different age groups have produced very different endpoints in terms of aortopathy. This is one dramatic one where both done by the Dietrich lab, who was the co-author on this manuscript before his untimely passing, but David's lab did TGF-beta 2 receptor deletion at younger mice at one age, and then had a subsequent publication at 11 months. And you can see that there was a very drastic difference in the pathology. And in fact, this has been a thing that Scott mentioned as well about the BAPN experiments. There's a very distinct age dependency in terms of these experiments. In terms of intervention, an issue that we're going to come up with a bit later on is, when does the intervention get given, and is it put at the time when there is a normal aorta or aneurysmal? Again, this is one example, and there's not a lot of examples of this, but this is when Jason Cook was in Keiko Ramirez's lab, where Jason gave TGF-beta neutralization at different times after birth. And the conclusion of this was that depending on the time of the intervention, there was quite a different output in terms of the pathology that was produced. So there needs to be a thoughtful discussion about the timing of the intervention. The duration is also, we think, potentially important. We tried to accentuate this because there has been many manuscripts of which have stated this is the characteristics of the aortopic tissue. Having said that, there tends to be a lot of heterogeneity in these models, both heterogeneity in terms of spatial as well as temporal. So this is one example in which a BAPN was given for 4 and 12 weeks. And you can see that in this model, there is, in some animals, you get this very profound descending disease, which is basically a blood clot at 4 weeks. But if you let these mice progress for another 8 weeks, it's a very different pathology. So in terms of reporting anything about the characteristics of the tissue, it really is important to make sure that it's clear that what the duration is and cognizant that that duration may change the pathology. We also put this into the recommendations in part because we know that we've had, especially when I was the interview editor, reviewers that seem to think that a publication requires 2 animal models for it to be acceptable for publication. We did state in this particular recommendation that we think that one model done very well with robust data is an acceptable approach to the acceptance for a manuscript. And then the statistics, we did bring over the fact that we do think that having robust statistics is important. We think individual data was helpful to get people to feel for the spread of the data. We have a lot of the group have experience where they've not been able to use parametric, which obviously is more more easy to get positive data. So we do recommend that they should be tests done to make sure that the parametric or non-parametric are being used appropriately. Certainly in the world of the American Heart Association, there is much discussion about small data sets. And in fact, for quite a few of the journals, there has been an arbitrary decision that groups of 6 or below cannot be analyzed by parametric tests. And so we wanted to bring that up to people just to make sure that they're aware of this potential constraint and know going into the publication that this might be something they should consider. There has been analysis showing that quite a few of the issues such as rupture are non-contiguous and they need different tests. And also making sure the appropriate tests are used for multiple groups and intervals. So again, in looking through the data, we've noticed a lot of use of t-tests, for example, for multiple groups and intervals. So that was my very quick overview of some of the major issues we thought about design. I'm now going to hand it over to Hisashi Sawada to talk about what we think is one of the most important things, which is measurement.
Hi, everyone. I'm Hisashi Sawada from University of Tsukuba and University of Kentucky. In my session, I would like to share some tips for thoracic aortic imaging using ultrasound in mice. As you may know, multiple approaches are available to visualize thoracic aorta in mice. That includes ex vivo, CT, MRI, in situ approach, and ultrasound. Among them, ultrasound is the most common mode to visualize the thoracic aorta. From 2015 to 2020, there are 99 research papers published in ATVV. In this paper, 78 researchers were used the mouse models. Then we investigate which approach was used to measure the aortic diameter as the primary endpoint and found that 65% of papers are using ultrasound to measure the aortic diameter. So the ultrasound is the common approach for the thoracic aortic imaging. The ultrasound is an in vivo, non-invasive approach that enable us to visualize thoracic aorta clearly. And you can measure the diameter like this. And we can see the dilatation aortic wall as aneurysm. There are several machines available, but the vivo system has been used as a common system for the mouse aortic imaging. So the originally 6060 was developed, and now F2 is the current version. This system has a high frequency ultrasound system. The high frequency is very important, required for the good spatial resolution. So this is an example image. The left is a Vivo 770, a little bit old machine. The Vivo 2100 is the machine that has a high frequency. Since mouse aorta is located in 5 to 10 millimeter depth from the mouse skin, so high frequency is required for the good resolution like this. So Vivo 770 is fine, but the 2100, you can see the big improvement. So the good resolution is very important for the aortic measurement, because to measure the aortic diameter, you need to draw the measurement line from the edge to edge of the aortic wall. However, the aortic wall in the old machine is fuzzy like this, but the high frequency machine is like this. So you can get the more authentic, reliable measurement. Another thing is probe position. To do the ultrasound, you need to put the transducer on the mouse chest wall. And there's two major probe position, right and the left parsonal view. The important things here is these two views provide a different the aortic images. So right parsonal view is like this. You can see the aorta is going up and going down, and you can see the aortic arch and the proximal descending here. In contrast, the left parsonal view is you can see the aortic sinus on left, and the ascending aorta is a little bit going up, and you can see the innominate artery here. So these two view positions provide a different aortic images. The important thing here is right parsonal view is good view for ascending aorta. The left parsonal view is good for ascending, but also sinus is good. The reason why the proportion is important is aortic measurement. When you measure the diameter, the ascending is, so for example, I use the exactly same mouth, same aorta, but the diameter in the ascending is 1.3 in right view, in left view is about 1.3, but the sinus is quite different. The right view provides 1.61, but the left parsonal view, the diameter was 1.76. Another important factor is cardiac cycle. So aorta is moving following during the cardiac cycle. So you can see the difference of aortic diameter at the systole and diastole. So when you measure the diameter in systole, the diastole, the diameter is different. For example, the aortic sinus at the systole is 1.89, but diastole is 1.76. And the systole ascending is 1.4. In contrast, the diastole is 1.26. So you can see the difference. A summary, for ultrasound is good more to visual the thoracic aorta, but there's important factors. So the important factors are ultrasound frequency, probe position, and the cardiac cycle. These factors has to be considered. And for reliable measurement, authentic imaging, you need to use the exactly same frequency, same position, and same cardiac cycle. So the take-home message here is be consistent for legal and reproducibility. Okay.
All right, thanks, Hisashi. So this last segment is something that the reviewers of the manuscript asked us to include. Basically, the issue of, has the translation been really good in terms of these models to give us predictive evidence in humans? And, this is kind of the classic example of something that was 20 years ago generated tremendous amount of excitement, and the hope, obviously, that losartan would be a very effective treatment for people afflicted with Morphans. This particular study stimulated, I think it was 9 worldwide clinical trials in which ARBs were given to patients with Morphans disease. This is a summary by Diana Milowitz, along with Kim Eagle and Dr. Hoffman-Bowman, in which, without going through the individual ones, in general, there was ones that different trials that really didn't show any efficacy, and some that showed rather modest. Probably the one that showed the most effective was the AIMS trial, in which it was the British trial using irbesartan. But I think the general feeling has been that maybe the animal experiment wasn't necessarily predictive of therapy in humans. I guess one of the things that we tried to go through in this particular manuscript is saying that maybe there are some issues that should be really considered a lot more in depth before we jump into a human trial. So one of them is considering whether the level of pharmacological inhibition achieved experimentally can be achieved clinically. So the issue here is that the way we give drugs experimentally tends to promote chronic inhibition. So, for example, a lot of the drugs are either given in diet, in water, or in which will cause fairly persistent delivery of the drug over the duration of feeding and eating, or even more consistently using LZ pumps where it's a very uniform 24/7 delivery. That necessarily isn't the case in humans where they're getting maybe once a drug diet, once a drug dose. And then also picking the right drug. So, for example, just to use a few examples of angiotensin receptor blockers, losartan is the original drug in this particular class, and it was a huge breakthrough when it was discovered. Having said that, it doesn't have a great half-life. It's a very short half-life, and it's not particularly bioavailable. It is actually probably not the most active component when you give losartan. Losartan is actually synthesized to an active metabolite, EXP3174, and it does have a somewhat more chronic half-life. But the newer drugs tend to be much better in this respect. So irbesartan, which I just mentioned, probably had one of the most efficacious results in the trials, has a much more extended half-life. And in fact, telmisartan is quite often quoted as 24 hours, even though these drugs come to maximal effect equivalently. They also are more effective. But also, this might be one of the more important issues, is that a surmountable antagonist means that if angiotensin is present in excessive amounts, it can overcome the effect of the antagonist, which is the case with losartan. But a lot of the more contemporary ARBs, like irbesartan and telmisartan, these are considered insurmountable. So in other words, even if there's a local buildup of angiotensin 2 at the receptor, they will not displace the agonist. So therefore, there's a persistence of response that may not be achieved in other drugs. So picking the right drug could be really important. It's also the discussion of making sure that we really have unequivocally robust statistical analysis and making sure that they're statistically robust. Having said that, sometimes you can get quite small effects, even though they can be statistically robust. And obviously, in these particular experiments, we're having very set conditions, which are very standardized, very routine. And so if we're just seeing fairly minor effects under these extremely standardized conditions, it may be expected that those very modest effects may not translate to significance once we get to the more obvious complexity and heterogeneity of humans. So having a very major effect, which is not a very objective tone, but it would be helpful. Another issue that has been discussed a lot is the fact that many of the studies, just because of the nature of the way the experiments sometimes can be done, is we are more determining whether an intervention is affecting the initiation of the disease. However, it might be that the propagation has a very different mechanism. And these experiments are much more difficult to characterize and much more difficult to do. But it would probably be helpful that prior to jumping into human disease, that we consider doing studies in which an intervention is given when there is clearly established disease, and then seeing whether the drug is effective under those conditions. There has been studies in other fields. Some of you might know there's a very famous analysis from Amgen about efficacy of cancer studies, in which they determined that a very small number of the studies they tried to replicate where they were able to replicate, but they did mention that those that were replicated, it was very obvious that they were much more comprehensive in terms of all the details they gave. For example, some of the things that we've just been mentioning, the sex, strain, age, and source of all the reagents. So it was, this article kind of, I think, created quite a mindset of making sure that we really were very open about very clear about how experimental studies were done if we really wanted to facilitate replication. And then another issue which has been discussed quite a bit is that, sometimes there's quirks of experiments that we are not quite sure of, but, means that one lab can get an effect. Again, I think if we are really going to jump this to humans, it would be helpful, although difficult, I will very much acknowledge, if the study was replicated in an independent lab, so that we really had a good, strong confidence that the effect was very reproducible, irrespective of maybe some minor quirks that may make it facility specific. So we collectively here tried to make this a fairly brief overview of, as I say, quite an extensive document, which I hope any of you who think about getting into this area will consider reading and using. And obviously, we and the other co-authors on this that were part of our Leduc network would be very happy to answer questions. Certainly, now we have an opportunity for 15 minutes or so of any of the questions at this point. We'd be very happy to answer. Lauren?
Sure. Dr. Daugherty, do you want to discontinue sharing?
Sure.
Thank you.
You
Dr.
go.
Daugherty, Dr. LeMaire, Dr. Sawada, thank you so much for sharing your time with us today. This was wonderful. As we wait for questions from the audience, I have a couple that I would like to pose. So everything you shared today is extremely important. There's no question about that. If you had to pick only one, which gap or inconsistency in preclinical thoracic aortopathy research do you think most urgently needs standardization?
I think part of the reason that we invited Dr. Sawada into this was because, as you mentioned, the vast majority of these experimental studies use ultrasound. The vast majority of them do use the visual sonics, which are, sort of revolutionized our ability to do these measurements. But, for the reasons that Hisashi mentioned, we have been concerned as the writing group went through to analyze the different ways that the studies were done, especially relative to the changes that were stated within the results, is that inaccurate measurements sometimes are equivalent to some of the changes that were represented. So that's part of the reason we had quite a heavy emphasis in this recommendations about making sure that the quirks of ultrasound were thought about, and as was mentioned by Hisashi, that there's be a consistency about the way it's done with full reporting on the mode of which it was done. So I don't know whether Scott or Hisashi got any of the thoughts.
Yeah, I think the points that you raised earlier about the background and the importance of how much heterogeneity there can be depending on the background of the mouse. Standardizing in that area, I think, is important if you're going to compare, results. And you could imagine a scenario where you try a therapeutic and you have limited effect in, one model because of the background of the mouse, and that you see a more profound effect in a different model. So I think to the extent that exploring different models, including across different backgrounds, is important to consider.
Great, thank you. Are there recommendations in the paper that you think could be particularly challenging for the field to adopt in practice? And if there's any advice on overcoming those hurdles?
Well, I think actually probably the last point I made might be one of the most challenging. We strive for doing experiments that are not just making great lab experiments and publications, but really are replicable across all people doing the same experiment. Having said that, some of these experiments are incredibly expensive to do. So I can see that there's a reticence to do an experiment in which, frankly, if it's replicated, many journals are not very welcoming to a manuscript that's basically saying, hey, we've replicated this seminal result. Combined with the fact that there's something different, again, I know journals, being a former editor, can be somewhat not welcoming to manuscripts that just say we got a different result from someone else, without that then provoking the need for a lot more extensive experiments to maybe explain why you've got a different result. So while I do think that having replication is important, I'm not naive enough to, I'm not that naive and realize that this can be quite a challenging thing to put into the recommendation.
Sure.
Yeah, Scott?
Yeah, I mean, similarly, one of the points I mentioned was particularly with studies evaluating new therapeutics, that an effect you see in one mouse model may not be consistent in other models. And I guess that goes both ways. You could could try a therapeutic in one model and not see an effect and abandon, that the idea that agent might be helpful. Whereas in another model, it may actually be effective. And so, and then the flip side is seeing a therapeutic work well in one model, but when you apply it to others, it doesn't work well. And that's where I think there'll be, challenges in translating which patients might be sort of best suited for that given therapeutic. So my bias is that promising new therapeutics ought to be studied across a variety of models. But to Alan's point, with the expense related to these experiments, that can be really challenging to do. I mean, we've even heard pushback against studying both in males and females just because of basically doubles the expense of the study. And we see submissions to our journals where they've only used, and this isn't just for aortopathy, but submissions to journals where they've only used one sex in their mouse models, and the rationale for only studying one sex is things like, well, we don't want to introduce the effects of hormonal changes that you would come up to be if you used the female mice, and frankly, the expense of having to do adequately powered experiments in both sexes. So it's expensive to cover all the bases, but I think that's where we ultimately need to be if we're going to identify therapeutics that are likely to be translatable.
Great. Our audience was a little shy to start, but we're getting great questions now. So first question. We currently deliver losartan in mice using osmotic pumps. Which administration route and frequency would you recommend to best mimic how the drug is taken in humans?
So I guess maybe I'll start on that one. I mean, the question, we obviously try and optimize our experimental situation to make sure we have consistency of inhibition. And so that's why, LZ pumps have been used considerably because they do provide a very consistent. So I think more the point is making sure the level of consistency of inhibition you get in the experimental animals, can you achieve that in the human situation? So, for example, we work a lot with ASOs, and we don't work with siRNAs, but they've been just amazing in terms of being able to do one injection and have a profound effect for 6 months. I intuitively think that probably will be better than getting drugs that have a very, daily big oscillation in terms of their effectiveness. So I don't know that I can give a very specific answer personally. I don't know that anyone else can, other than the fact that we need to try and get a very consistent inhibition.
Understood. What is your opinion on the need for add-on of the drug of interest to baseline beta blocker or ARB administration, given that patients will not be taken off of their standard medication?
I guess from my perspective, it's that this balance of doing experiments for therapy versus the reality of academic life, because doing those type of experiments are important and they can be done. I do actually think they're important to do again before we dive into a clinical trial. But I again recognize many people's reticence of doing that type of experiment because it might, from an academic perspective, not seem like a very mechanistic insight into the disease process.
Yeah, I mean, I agree that on some level, it would be ideal to replicate as many of the factors as possible, including the administration of the other commonly used drugs, but feasibility really becomes a challenge. And so I think from a practicality standpoint, I don't think those are certainly not necessary. I don't think those are necessarily, certainly not in the earlier stages of evaluating a therapeutic.
Okay, thank you. Doing intervention studies rather than prevention studies is not popular since it's likely that 9 out of 10 studies will not be generating positive data. How are we going to publish all of these negative results that are so necessary to make publicly available?
Well, Vivian, I have no idea, to be honest. I mean, I agree with the complexity of doing so in our world, for example, doing angiotensin for, say, a month to make sure there's reasonable disease there, and then giving a treatment at that time means you're going to lose some animals during that interval. You might have a few non-responders, and then you've got to stratify. And then, at least during angiotensin infusion, there's a relatively modest expansion between 1 month, and most of these experiments in our hands, at least, we used to take them out for another 2 months. So you're talking about, a 3-month experiment in which you're giving a drug persistently during that time. And, frankly, we've had lots of situations like I think you have, Vivian, that, let's say, wasn't a very exciting end point. Having said that, I really think it's critical that we publish negative data. So I know that's not necessarily a very popular editorial thought, but I do think we need to think about that.
Yeah, agreed.
How do you think mouse models fit in with human models or stem cell systems in the preclinical space before we initiate clinical trials, particularly given the push by FDA to move away from animal models?
Yeah, Sanjay, as you know, we're very much being pushed to think about models other than animals. So I think there's obviously many people, including yourself, advocating for IPCs, and I think there's obviously some very valuable information that could be achieved. And probably the biggest shortcoming is obviously aneurysmal tissue tends to be very complex, multiple cell types, and so it is a case of whether we can consider experiments for the IPCs or other different systems that are avoiding animal usage can really model the complexity of the human disease.
Yeah, it does remind me of some work that one of our collaborators, Jay Humphreys, is doing with the group at Yale to create informatics approaches to predicting different perturbations on the aortic wall and potentially therapeutics. And these are a multimodal model that considers different signaling pathways through different cell types in addition to the biomechanical forces on the aortic wall. And by networking all of those different aspects together, is hope to be able to provide an opportunity to do in silico mechanistic studies that would then could be used to better inform the more definitive animal models. I don't know that we're going to get completely away from animal models for this disease in the near future, but perhaps be able to get more selective in which studies go through an in vivo experiment by using some of these computational tools.
Great, thank you. We have one question left, unless anyone is currently feverishly typing. We see different ages of studies for FPN1 C1041G, for example, mostly 3 months. Do you think standardizing the age of study would be important?
Well, so in our experience with that particular model, we've actually tracked them for over a year, and in part because it's a relatively modest model. So if you want to do an intervention, it's good to have a very robust control response so you can give an intervention to see whether it's very robustly changing it. So I'm not sure that, from our perspective, the 1041, I don't know that there's any single time point that we should look at. And again, because we see temporal changes over time, again, I know it's not very easy because of just the expense and the logistics, but it's helpful to do sequential studies over different time points just to see whether pathology has been altered and dimensions have been altered.
Great. Many thanks to those who shared their questions and to our speakers for addressing them. Let me share my screen for just one more minute. Okay. Before you go, please take a moment to share your feedback on this webinar by visiting marfan.org/medsurvey or scanning the QR code that's on your screen right now. I'll give you just a second to grab that info. It's so important for us to hear how we're doing on webinars like this, so please don't be shy. Again, thank you to our speakers for sharing their time and expertise, and thank you to those who attended today's webinar. Take care.
Thanks, Laura.
Thank you.
Thank you all.